My second talk will be on fracture-related infection around the elbow. This is a complication that we don't see that often. However, it is a very challenging one because we have to achieve infection control, and when the fracture is not healed, we have to achieve bone healing as well. This has been reported in about 3% of closed fractures and 7% of open fractures in this large series from Dr. Ring's group. And I'm going to go through the definition and diagnosis, some predisposing factors, and management. For infections in discrete anatomic areas or in specific situations, for example, after joint arthroplasty, we have specific criteria. And for example, with periprosthetic joint infection, we created initially the MSIS definition back in 2011, which has been modified since. However, for fractures, until recently, we did not have a similar definition. And it was very interesting. In this study, we looked at orthopedic studies, and we found that in the vast majority, there was no definition of infection, even though infection was an outcome variable. So we had several meetings in which we created a consensus definition of fracture-related infection, where we have confirmatory criteria, a sinus tract or wound breakdown with communication to the bone or the implant, or purulent drainage from the wound, or presence of pus during surgery. And here we see an example. And unfortunately, we may see this with plate fixation of olecranon fractures when we have wound issues, and sometimes plate fixation, when inappropriately done, can contribute to these problems. Having two distinct cultures with the same pathogen, deep cultures taken during surgery is another confirmatory criterion, and histopathology can be helpful as well. We have a lot of suggestive criteria that do not confirm the presence of infection, but they should raise suspicion. A lot of clinical findings indicating inflammation, the presence of fever, wound drainage, or a new onset joint effusion, inflammatory markers when they're elevated, they suggest infection. When we have a single culture, and some radiological findings may suggest infection, for example, osteolysis or non-union. However, this may be the result of a non-infectious process. In this study, we looked in more than 600 patients, trying to assess the sensitivity and specificity of these criteria. And we found that when patients had at least one confirmatory criterion, the sensitivity was almost 98%, and the specificity was 100%. So how do we integrate these in our diagnostic approach in a patient where we suspect infection around the elbow? Starting with a very good history. So if the initial injury was an open fracture, we should have a high index of suspicion. If the patient had prior procedures, especially for wound problems, if there was any drainage or delayed healing of the wound, and if the patient tells us that there was antibiotic administration or a previous diagnosis of infection, then it would be helpful to get all previous data from the prior treating physician. And here, of course, this is an extreme example. Here we can actually see the olecranon plate through the wound. Obviously, this fulfills the confirmatory criteria for infection, and we can establish the diagnosis. And interestingly, some of these patients, most of these patients are not systemically sick because there is no accumulation of pus. It just drains through the open wound. Inflammatory markers may indicate infection, however, they do not confirm infection, and also normal values do not rule out infection. However, they provide baseline values to monitor the response of the patient after our management. As I mentioned, the imaging studies are not so helpful for the diagnosis of infection. However, they can provide important information about the status of bone healing, the status of the implants, And this information is very important for our management algorithm. MRI can be helpful to demonstrate abscesses, sinus tracts, and this can help us with surgical planning. Nuclear studies can be helpful. However, some studies have found them even less useful than the inflammatory markers. And coming to the intraoperative cultures, which are very helpful, they confirm the diagnosis when we have two. We found in our validation study that even one culture, if it was one culture with a pathogenic organism, was very specific. We need to get at least 3, preferably 5 deep samples. In chronic cases, I also get mycobacterial and fungal cultures as well. And we should not be getting superficial or sinus tract swabs from these cases. Deep cultures are much more helpful. However, we may still have false negative cultures, especially if the patient has been on antibiotics. For this reason, it will be best to keep the patient off antibiotics for 2 weeks. And another reason is that, especially in the upper extremity, we may have pathogens of low virulence, such as the C. acnes, and also bacteria may grow on biofilms and may be in a low metabolic state, and we may not easily identify them with cultures. Actually, in many cases, we may have an infection without any clinical and without any laboratory findings. And then, for example, in the management of a non-union, if we send cultures, then we get these positive cultures, and the term surprise positive culture has been coined. And here we see that the rate goes all the way up to almost 30%. But why do we have an infection when there is no clinical or microbiological or laboratory indication? And biofilm formation is a key factor. So biofilm is a highly structured community of microorganisms that are phenotypically different than planktonic microorganisms. They exhibit a low metabolic state, and they, after attaching to the surface of foreign bodies or dead tissue, then these microorganisms become very resistant to host defense mechanisms and antibiotics. So we need to have a high index of suspicion. And also something that I would like to point out for the diagnosis of these infections is that we need adequate follow-up to make sure that the patient has done well after our initial surgery, especially in open fractures. The CDC changed their definition of infection, the time frame for that they used in the definition of infection, from 1 year down to 90 days. And I've always thought that 90 days is a very short time frame. We see infections develop beyond 90 days very often. And for this reason, with colleagues in Belgium, we looked at a large number of patients with long bone open fractures, and then we looked at the time frame of development of infection. And we found that a 90-day follow-up captured only 64% of infections. 1 year follow-up captured almost 90%. Now, going to predisposing factors, here, this study mentioned smoking as a pacing factor. They did not find a significant difference between open and closed fractures, but we know that open fractures are contaminated and they do have a high risk for infection. So I think that there was a power issue there. And as far as treatment, they found a significantly higher rate of infection when an external fixator was applied or when plate fixation was used. However, these fixation techniques are going to be used for more complex injuries. A quick note about plate fixation around the elbow. It has been shown that there is a higher infection rate in simple olecranon fractures. That previous randomized controlled trial by Duckworth, and a recent one that that was just published ahead of print, described a much higher rate of infection in simple olecranon fractures. So I think we'll need to take this into consideration. However, a lot of times I think the infection is the result either of the escape of the olecranon fragment, as was shown in both of these studies with these examples, or by leaving the plate too proud. So I think we need to bring the plate as close to the olecranon as possible, because if it is proud, the very thin soft tissue envelope is going to see a lot of tension after closure, and then this will predispose to wound healing problems and then to infection. And I would like to go through the principles of management. We need to control infection with debridement and antimicrobial therapy, both local and systemic. The fracture needs stability. We need to establish soft tissue coverage if there are wound issues. And in non-unions, we need to promote bone healing with bone grafting and manage any bone defects. The exact plan will be based on the assessment of many factors. And now, if the fracture is healed, our goal is infection controlled. However, if we have an acute fracture or a non-union, then we need to achieve both infection control and union. So obviously, this is a lot harder. So if the fracture is healed, then debridement, removal of implants, we don't need further stabilization. So this is a much simpler situation with a very good outcome. If we have an acute healing fracture, now the key question is whether the implants are providing stability. So if we maintain the implants, then we may have persistence or recurrence of infection. However, if we have stability, then this can help with controlling the infection, and then we can remove the implants later. So we have these two options. We can remove the existing implants and restabilize with new ones, trying to maximize the control of infection, or retain the existing implants, wait until fracture healing, and then remove them. And it's not always a straightforward choice. Around the elbow, we have limited bone stock. So especially in complex fractures with plate and screw fixation, if we remove the existing implants and we try to restabilize the fracture, we may not be able to get good stability. So my preference is to retain the existing implants if they are stable, and then remove them after fracture healing. This is a study that looked at fractures at all anatomic locations, and they found that when the implants were retained, they achieved union in 73% of cases. However, there was a recurrence of infection in 30%. And this is a recent review that we did, and we found that as the duration of infection becomes longer, then the control of infection becomes harder. However, as the duration becomes longer, if we have stable implants, we may be getting closer to fracture healing. So it is an individualized decision that will require assessment of multiple factors. Now, if the implants are unstable and have failed, of course, there is no, we only have one choice. We need to remove the implants, perform a debridement, and restabilize the fracture. Again, another example, the implants are failing. And here's another example. We don't have an adequate reduction. We have a big gap, an interarticular screw, and we need to revise the fixation. Going to an infected non-union, we should always suspect infection. As I mentioned before, we can have surprise positive cultures in all these cases, and we need to optimize the status of the patient beforehand. And we need to assess whether satisfactory function can be achieved, because pre-existing or coexisting problems may preclude functional restoration. So we may elect antibiotic suppression or just debridement without reconstruction of the joint. And here is a patient that saw this failed fixation. However, this patient also had the pre-existing childhood injury, and we can see the severe deformity of the joint. So in this case, he had the limited pre-existing function of the elbow. And here we see a patient with AIDS with a very low CD4 count. This is a patient that I fixed, developed a severe postoperative infection with osteolysis, failure of fixation, and then a lot of bone resorption. And then finally, at this point, it was infection-free and she declined any further treatment. So usually infected non-unions are treated in stage fashion. We can do everything in one stage, but my preference is to stage this. Implant removal, debridement, cultures, antibiotics, stabilization of the fracture provisionally, soft tissue coverage if needed, and then finally the definitive fixation with bone grafting to promote healing. Debridement is a key principle. This will help us remove biofilm. We need to have healthy bleeding bone at the end of our debridement. Antibiotic therapy, both local and systemic. Local antibiotic therapy can achieve high concentration of antibiotics in the local tissues. This needs to be combined with systemic antibiotic therapy. Our preferred duration in our center is 6 weeks, but a lot of authors have recommended 12 weeks, and of course, with consultation with an infectious disease specialist. Here's an example, failed fixation. In this case, the nuclear imaging studies also highlighted the presence of infection, debridement, antibiotic beads, fixation with parallel plates, and then and bone grafting. And here is the patient at 2 years. And here's a patient that came to me 5 years after this intramedullary nail. No clinical or laboratory signs of infection. However, the cultures were positive for C. acnes, and here fixation with a plate, bone grafting, and here he is with full range of motion and return to construction work. So every patient with infection after fixation of an elbow fracture presents a unique problem. The management requires a detailed surgical plan and multidisciplinary collaboration of orthopedic surgeons, infectious disease specialists, and microvascular surgeons. And with this, I want to thank you again for the invitation. And it's always great to participate in this wonderful elbow course. Thank you.